Welcome to Season 2 of Talk Lab to Me. Talk Lab to Me is an engaging discourse podcast hosted by COLA, a leading physician-directed accrediting organization that provides education and accreditation services to laboratories of all sizes. The podcast covers a wide range of topics, including the latest developments in laboratory science and medicine, as well as in-depth interviews with regulators and industry thought leaders about the importance of regulatory compliance. Welcome to Talk Lab to Me. Our guest today is my friend, Dr. Rodney Rohde, who is a Regents Professor for the Texas State University System. He is a University Distinguished Professor and Chair for the Medical Laboratory Science Program and serves as Associate Director for Translational Health Research Center for Texas University. He is a Global Fellow, a Fellow of Association of Clinical Scientists, Honorary Professor of International Studies, and an ASCP board-certified specialist in virology, microbiology, and molecular biology. He has served as a public health microbiologist and molecular epidemiologist with the Texas Department of State Bureau of Laboratories. And he has also served 2 terms as a CDC visiting scientist. He has published a wealth of research articles, abstracts, chapters, 2 books, and is a keynote speaker with over 250 presentations at all levels. Welcome to Talk Lab to Me, Dr. Rohde. We are so happy to have you.
Thank you so much, Danielle. It's a pleasure to be here. We just got to visit with each other last week at the COLA Laboratory Enrichment Forum, so it's great to see you again. I'm really excited about this topic today.
Excellent. And for those who are unable to visit with us in our 2026 Laboratory Enrichment Forum, which was a great time, wonderful knowledge sharing, our registration for 2027 Laboratory Enrichment Forum is now open. So let's talk lab. I want to start off hearing what got you into the public health sector? What was your journey?
Yeah, great question. And it's part of the story that I often tell people that are getting to know me. So it kind of is an interesting journey. I came to college thinking pre-medical, medical school, like a lot of people do in our field, but quickly changed my mind when I took my first microbiology course as a sophomore. So that was my first really great time to see it, that invisible microbial world that really excited my ideas around infectious disease and pathogens. And I was off to the races at that point. So I majored in microbiology as an undergrad. I stayed on and picked up a master's degree in virology, which was kind of interesting in hindsight because all of my wet lab research was with poliovirus and looking at antiviral effects against poliovirus. And then I was finished, had 2 degrees. And Danny, during that time, I had no clue about the medical laboratory and really not the public health laboratory. I was rolling along thinking I was going to go to work in a hospital lab when I finished. And as you know my story, I actually didn't have that important credential. So my advisor was like, "Hey, have you ever heard of public health labs?" And I didn't. And so he introduced me to the Department of Health in Austin. And lo and behold, I got a job as a microbiologist there and spent a decade there. And my primary areas when I started was virus isolation. So I was old school learning all of the cell culture and immunoassays, really just at the advent of molecular diagnostics. So it was coming on board, but it wasn't quite there yet. Learned a ton in old school virology and monoclonal antibody techniques and cell culture. And that's when I first set for my specialist in virology because I was seeing people with all these credentials. And that's really was my introduction to the medical laboratory, was I was learning that part. Then I quickly had an opportunity to jump to rabies and arbovirus. Loved that area, stayed there for about 7 years, was part of the initial oral rabies vaccination program, which eliminated rabies, canine rabies, from Texas. And still, probably my primary research area is zoonotic disease as well as antimicrobial resistance. And then, as you know, I had an opportunity in 2002. My alma mater called and I did an adjunct role. And then I ended up finding out about a position in the medical lab science program, which I never knew existed here. And here I am sitting in 2026 as chair of that very program and have worked my way up through the the academic ranks. And, my passion really is still public health, medical laboratory, advocacy, science communication, and the research that I perform.
I love opening with what's your journey because you mentioned about not being fully aware of the role of public health laboratories early on. And I think that happens a lot. So it's so important for experts like yourself to share their story for those out there who may be unaware of such avenues. So, can you explain what role public health laboratories play in protecting the health of our communities?
Sure. I mean, the simple answer is that public health laboratories are the primary diagnostic defense system against population level health threats. So when you think about that effort, right? And this is across all spectrums. So it's not just infectious diseases, which I'm working in, but they also test samples to protect entire communities. So we're a little different than a medical or clinical lab in a hospital setting because they focus on individualized patient care, right? We at that level are really generating objective scientific data to guide local, state, and national health policy decisions. So, for example, in Texas, there's an entire wing in the public health laboratory that does nothing but water testing, right? So they test all the water from all over the state, whether it's freshwater or saltwater areas. They're looking for not only infectious pathogens, but maybe mercury, maybe lead, maybe chemistry level types of information. So when you think about that, air, water, human health, um, just a massive area of effort that most people don't understand in the general public until you have an outbreak or until you have lead issues like we saw in Flint, Michigan, or until there's a national emergency like a hurricane that wipes out New Orleans. Then you really are like, where are the public health people? And so I often tell people that we're somewhat like the medical lab and that we are a little bit invisible, but we are always doing critical work protecting the public, even when they don't know it.
So, some of the key functions of public health laboratory are it's very vast. Where does that play when we talk about disease surveillance?
Sure,
Where does the public health laboratories really show up in that
sure.
track?
So again, kind of the key difference, I'm just going to make this analogy because I think it helps sometimes. In a medical laboratory setting, it's real time. It's real time. We're looking at individual patient or maybe several patients, and we're trying to find out if they have the flu because they want help. They want antiviral help, or they want to rule out a bacterial infection. It's really real time, right? And that's always happening. For us in a public health, it's really about continuously testing and tracking baseline prevalence of known pathogens. So to use that same analogy, if there are in Texas, if there's an outbreak going on with flu, different hospitals will send in certain isolates of flu or samples from patients, but it's not like a stat test for us. We are going to be testing multiple samples of flu isolates to determine what's the variant that's circulating in Travis County, or what's the primary variants circulating in Texas. And then that data is used next year for prediction of better vaccines and things like that. We provide specialized high testing complexity around commercial testing and maybe food microbiology that hospitals don't do. So again, if there's a big foodborne outbreak, an ER in a hospital might start getting those people coming in with diarrhea and vomiting and all those things. But what's happening? Where did it start? Where's the epidemiology around that? That's what public health labs do. They'll be looking at all of those samples, doing both primary isolation, identification, and then what's the genotype, what's the strain? Is it tracked back to a ice cream producer? Is it tracked to a beef slaughterhouse? What's happening? So it's more of an outbreak investigation. And again, like I mentioned earlier, from water to food to vectors. We used to speciate and test mosquitoes to see if there's dengue in Texas or malaria, and try it even on the preventative side. So we're often looking at sets of specimens, for example, mosquitoes, to find out before we see an incursion of, say, yellow fever or dengue, because we're testing them in pool testing and we're looking at a high number of samples. And then ultimately, we're working with state, national, local authorities to really deliver that epidemiological data, to map disease, try to figure out what's happening in real time and become part of the solution if possible around an outbreak.
When you mention being proactive to things, it made me think about areas of preparedness. So, when it comes to public health laboratories, what are some lessons we have learned from the COVID-19 pandemic that public health laboratories prepare the communities, whether through education or information, or like you were just explaining, being ahead with different things around the world?
Yeah, so boy, that's a big topic, right? I mean, I hope, right? I hope we have learned some lessons from COVID, as well as when you think back in my time and perhaps yours. I remember when HIV was a big deal. I was in high school. I'm old enough to remember that panic and that. So part of what we do is try to answer questions. We try to do it in a scientifically accurate way, in a timely way, as well as we can, to provide real time information to the public, to the government, to physicians about what's happening at the ground level. Without public health, Danielle, I always tell people the United States and in a way the world is flying blind, right? So surveillance, diagnostics, on the ground, bootstrap epidemiology, working with laboratory diagnostics to figure out what's going on. That's a bigger picture worldview versus, say, a hospital laboratory. They're still connected. Public health is hospital health. It is community health, but it kind of scales up when you get to that type of level. So, in that sense, when you think about COVID-19 lessons, these are pretty tried and true lessons we know about. We quickly learned that we need to be thinking about scalability. How quick can we get a simple test validated and out? And really, the CDC was not built to be a reference lab. That was a quick lesson we learned. CDC cannot handle, within a 2-month period, hundreds of thousands of specimens because it's a pandemic going on. You need to spread that diagnostic understanding out to every reference lab, every hospital, who can help you, public health labs. I should mention here that there's a whole system in the United States called the Laboratory Response Network. Every state has an LRN lab that is tied to CDC, and they're kind of the hub for testing of that state. So Texas, it's in Austin. We have the Department of Health there. So that was a big deal. We learned about supply chains, how critical it is not to have one single source supply chain. I think that was a huge lesson. Who would have thought? I mean, who would have thought? It makes total sense in hindsight, like most lessons, like, well, that was not very smart. Let's pick one manufacturer and hope they're always available for us. That's crazy thinking when you have a global pandemic. Surge capacity, how do you handle surges in hospitals and how do you spread out those tests and those different resources to hospitals and public health labs? Um, Data, right? I think the biggest thing I talk about sometimes is if I could back up the horse into the barn back to 2018, 2019, and I think we knew this, but when it happens, it happens. And that is emphasizing how public health and CDC and other laboratories that do this type of work to be very transparent, to be very methodical about reporting. Without reporting, you're flying blind. We need interoperable lab systems. We need automated cloud reporting types of systems so that we're all on the same page, so that we're not caught with our proverbial pants down when this happens. We really need to be thinking about that. And even coming out, right? Some of the lessons of, like, right now I'm doing it with hantavirus when people are asking me about the cruise ship. Here's what we know right now. We think we know a lot about hantavirus based on research and history, just like we thought we knew a lot about SARS because we had had two other variants prior to 19. But we don't know everything, right? And viruses mutate, viruses change. People are all they're talking about right now with hantavirus is this Andy strain. Is it person to person? Maybe, maybe that's the best answer. And we're going to watch that. We're going to follow that and be transparent that, tomorrow we might have a different statement about transmissibility of the Andy strain. We're learning in real time. It's novel with respect to when SARS came through. And so I think that's so important. And why I'm here talking to you on this podcast is science communication, health literacy. The world has to take a step back and realize that Dr. Rodi or Dr. Hotez or Dr. Fauci or whoever is speaking to the world or the public can only know what they know in that spot. They can predict, they can make educated guesses based on research, but they could be wrong. And that's what science is all about, testing hypotheses, moving on when you find out what's wrong and fixing it as soon as possible.
I think about the introduction from being a hospital MLS to public health. It was definitely that you mentioned the relationship. It was a resource relationship. I remember us coming in contact with certain specimens, excuse me, a while back, and it's let's go to the public health laboratory.
Right.
Let's get information and resources on our next steps. So I think that is really important for people to understand that very necessary relationship between the public health and hospital or other facilities, and especially when information can change so quickly, as you mentioned. So it needs to be smooth communication. Health
Right.
literacy is so important for what we tell our public. Not only are we educating ourselves as laboratory science professionals, we have an ownership to help
Absolutely.
educate the public.
We have a professional responsibility and accountability. I just recently did an ASCP CDC building bridges webinar, and I spoke with two other experts, and it was all about misinformation. And one of the things we all kind of quoted, and we kind of say this a lot, misinformation, when it's out of the door, you know, it spreads faster than an actual virus, faster than a pathogen due to social media, due to amplification by people who are looking for that type of information. Whether it's a bad player trying to push things to sell goofy, therapies and things like that. All of that's in play. And so, as medical lab professionals, as public health professionals, as physicians, as nurses, whoever you are, I think you have an absolute professional and ethical professional responsibility to stomp out that misinformation as you are able and to not amplify it. Don't hit share until you know it's accurate. Just take a step back. It's okay. You don't have to be the first person to share something. Give it a look. Maybe check it out. Maybe reach out to that person or reach out to that agency and go, "Hey, this doesn't look right. Are you sure this is what you want to post?" That takes effort, right? And that's something I learned during COVID, that you can you can be challenged in that way. Like, I was trying to jump into every chat room, into every statement, and that's hard too. But you can make some broad types of posts and broad types of interviews, go on podcasts, go on webinars, and do your very best as a professional to stamp that out. It's just no good. It can harm people. It can set people up for problems if it's vaccine issues or therapies where people are relying on something that has nothing to do with an antiviral. So just a ton of misinformation out there that we have a responsibility to deal with.
Absolutely. And if you're that one person in your family that people come to for that medical or science
Man,
advice, it is very
right
easy to
on.
get brought into some of that miscommunication. So, as we've been talking about where we are very initially with the hantavirus, I appreciate you sharing that article from your school. Can you tell me a little bit more about that article? And let's talk about what laboratory science professionals at this current stage, and I stress this current stage because things are changing, should be aware of when it comes to our laboratories.
Sure. So I'm pulling it up right now, and I just shared this with Danielle. My university, Texas State University, asked me to create a short, accurate article regarding the current cruise ship outbreak. So the title of the article is Five Questions Answered About the Current Hantavirus Cruise Ship Outbreak by Texas State Microbiology and Virology Specialist. That's me. And so it just goes into, what is hantavirus? Why is a cruise ship outbreak so concerning to the public? Why is it all over the news, right? It's everywhere. Then the typical signs and symptoms to be watching for. Is the public at risk of a larger outbreak? And then a little bit about treatments and vaccines, and then some closing thoughts. So, just to mention the outbreak where we're at right now, this occurred on a Dutch expedition cruise ship, the MV Hondius. and it certainly got into the news really quickly after multiple passengers became ill. 3 people that we know of had died so far. This is as of about Tuesday of this week. The WHO, the CDC, and others are monitoring passengers and tracing contacts across several countries. So this is on the just like monkey or just like mpox, right on the hind end of the pandemic for COVID. We're seeing this happen more and more, right? And so what hantavirus I think has shown us is another reminder that are we prepared, not only as a United States but also as a global entity. About 11 people around the world have either been confirmed or suspected to be tied to this cruise outbreak. It's ongoing. 18 Americans were actually on the cruise ship linked to that outbreak, and they're being watched. I think most of them are in Nebraska. Some others are in different quarantine centers. So we're keeping an eye on them. And this is that part of real time transparency. You're seeing a lot of stuff. Most of it looks pretty good online, but be careful. We do not believe it's the next COVID pandemic. Hantavirus traditionally is picked up through swept up or kind of when things are cleaned out in really tight spaces like attics and barns and chicken coops and things like that from rodent droppings. So most hantaviruses are shed in rodent urine and fecal content. That's the primary way we get it. It can occur person to person if you're tight, close contact for a prolonged period of time. That's what the data shows us, Danielle, from past issues, and it's typically with this Andy strain. But we're watching it, right? We're watching it because we're seeing a few more people show up positive or a few more people dealing with it. And so the Andy strain, I went and did some digging on this. The data we have in the past is about a 4 to 42-day incubation period. So the important dates are going to be the next 2 to 3 to 4 weeks. What's going to happen? Are we going to see more cases? Are we going to see more mortality? People may not know this. I started doing hantavirus work back when I was at the health department with the rapid response team because Texas, hantavirus became famous in the U.S. in the Four Corners region. So if you know where the Four Corners region is, kind of Texas, New Mexico, Arizona, those areas. And we would occasionally have a death in an individual in Texas, in far west Texas, right on the edge of New Mexico, kind of like where our measles outbreak occurred. And there's a lot of rodents out there. There's a lot of areas for rodents to be. And occasionally a person would succumb to it. And when that happened and it was confirmed, we, the rapid response team, would go out to those areas. We would set up camp in the middle of nowhere and this is all my friends in wildlife biology. I learned how to trap rats and rodents and stuff in and around people's homes, maybe their workplace. And we would, in those areas, we had set up makeshift tents, and we would sit there at tables under tents and we would dissect and do necropsies of rats and things like that and submit different tissues to the Department of Health lab to do serology and primary virus isolation for hantavirus and document what strains were part of it. So I loved this job when I first had it, right? I mean, I got to leave the lab and go out into the field. It was the best thing about my job. Still miss it, actually. And that was the early goings on of what. So hantavirus is not new, I guess is my point. And we've learned a lot about it. Back in the day, there are times where people had a 30% mortality rate because it caused acute respiratory distress. Their lungs were filled with fluid. They had a hard time breathing. Kind of sounds similar to COVID, right? I mean, so this was a big issue. That's gotten better. There are some therapies and different things you can do, but it's still dangerous, especially if you're immunocompromised and you have other issues going on. Interestingly, before I turn it back to you, this cruise ship, patient 0 and patient 1 are thought to be, they picked it up before they got on the boat. They were bird watchers. And guess where bird watchers love to go? They like to hang out near landfills because lots of birds come into these places. And there's where an opportunity for rodent waste is everywhere. So hypothetically, we believe, and when I say we, those who are doing these investigations think that they probably picked it up near a landfill, climbed on board, and then the rest is history. That person to person stuff started happening. So that's where we're at right now. There are no true great approved specific antiviral treatments. There are some that that are being tested here and there, like ribavirin and things like that. A lot of it's supportive treatment, especially oxygen therapy and intensive care. If they have severe lung involvement, it's often called hantavirus pulmonary system or syndrome, rather. There are some, like I mentioned, experimental antibody therapies and vaccines, but that progress is kind of back and forth due to funding and things like that. So when I think about this right now, talking to you, I really think it really stands as another sobering reminder that zoonotic diseases remain one of the most unpredictable threats to global health security. We need to be supporting public health, period, globally, not just in the United States, because without those experts on the ground, without those scientists in the lab, without those epidemiologists cranking data, without sharing that in research, we're flying blind. I mean, the whole concept of One Health is animal health plus human health plus environmental health equals One Health. And without that, it's going to be a problem because we all live in this era of rapid international travel. We got new ecological disruptions. We're living in different places, a lot of interaction with, wildlife reservoirs and things like that. So we must continue to invest in surveillance, laboratory diagnostics, emerging pathogen research, public communication grounded in evidence rather than fear. Preparedness is not simply about responding to the next outbreak, it's about recognizing that our interconnected world requires constant diligence, collaboration, trust, scientific literacy to protect. So I'm on a platform here. I'm telling your audience this is really important, Dr. Duncan. And so I just hope we can climb on board with that support of public health. More than ever, we don't need to be cutting funding or cutting positions or doing things. I'm all for more appropriate ways to use money and revenue and be more better stewards, but we certainly shouldn't be cutting programs in public health or scientists or scholarships, for students, any of that stuff. You don't build, as you don't build a medical laboratory scientist overnight. You don't build a public health professional overnight. You don't build a nurse or a physician overnight. So when we lose all these people for whatever reason, we're really hurting ourselves with respect to being prepared for the next outbreak, even a small one like this one, right?
So, with that being said, as a laboratory, this is going to be a little bit of a two-part question. From a
Okay.
laboratory science professional, how do you prepare yourself as far as keeping up to date and also paying attention to what is changing and how it could affect your day to day? And from an organizational point of view, how do you prepare your laboratories? My first thought of with the laboratories, going back to understanding how to get those instrumentations up and running, getting those procedures, getting people trained. But I would love to know your thoughts in not just getting prepared, but us staying prepared as an industry for these changing factors.
Yeah, so important, so important. And this takes can do attitudes and certainly takes funding. But I think part of it, and I think back to my public health training, right? If you're not prepared, right? And there's some famous military leaders who often, I'll mess up the quote, but basically training and exercises is sometimes never needed or never utilized in the way you think they're doing, but it's the most important thing you can do, right? If you're not training and drilling and practicing, then you're not as prepared than if you were doing that. So I think implementing at the public health level and even in hospital laboratories in some sense to have regular kind of execution of blind proficiency testing, challenging staff to think about simulated unknown pathogens. This takes effort. I've even brought this up with our professional organizations about this could be a curriculum priority at some point in the microbiology area about how do we prepare students, future professionals, to think this way, to think systematically, to think more than just your one hospital lab, but your community, your state, and things like that. Another one that's kind of tough, but I think is important, is just-in-time training. This we learned during COVID. I mentioned earlier that CDC is not a reference laboratory. We can't expect them, especially now with all the cuts and the loss of personnel, to be able to do 100,000 specimens in 2 or 3 weeks. We need partners. We need rapidly deployable, modular, micro molecular units where we could fly in or helicopter into areas where you might have to actually send professionals to do the lab work, like a military excursion. They're in tents or they're in modular buildings and they're doing molecular testing and things like that. That takes money and that takes effort to where you have those resources ready. And I know this might make sense. It's hard to do in practice, but you have to check it. You have to make sure it's ready to go. You have to keep QC and QA on those types of activities, because if they're sitting in a warehouse for 3 years, technology changes overnight right now, whether it's molecular or AI or whatever you're dealing with, and you almost need a full-time person and team to kind of be doing that types of stuff. It makes me think of kind of our emergency management team that we do with, we learn those lessons from Katrina, like hurricane stuff. We need people that are infectious disease experts, physicians, the whole team that can step in level 3, level 4 types of environments. But we need that ongoing education through CDC. We need a strong CDC. I'm going to keep advocating for it. I love the place. I'm worried about it, but we can't give up on it. We must infuse that with constant federal educational platforms, certified and expertise personnel, and state of the art, up to date, real time protocols, and all those things. Again, that's not easy to do, I understand, but we better try to get as close as we can to that level with respect to that ongoing preparedness. Preparedness is not a weakness. It just isn't. You never show up for a job without preparing. You never show up for a relationship without preparing. I mean, you have to prepare for these things, or we're going to be caught with our pants down. And so we really need to. I think professionally and personally, that's Rodney's viewpoint. You know me. I'm a big public health advocate, and I just think it is one of the most important things we should be thinking about from a health standpoint right now.
As we talk about a lot of these emerging viruses, what recent advances in testing and diagnostic technology do you think has happened to help public health laboratories detect these things earlier on?
Yeah. So this is the geek stuff, right? That we like to talk about if you're a micro or molecular person, and even the other areas of the laboratory, right? Because sometimes pathology and things like that might be really critical. But certainly in the world of infectious diseases, I would throw in several very current and really evolving technology. The most exciting thing for me about AI is not always just the information side, but how it will help us think about new vaccines, think about new therapies. That's on the therapeutic side, but also the diagnostic side. All right. So the idea of things like metagenomic NGS sequencing, next generation sequencing, that has been, life changing in the world of diagnostics, allowing us to identify unknown pathogens, sometimes even without specific primers. Some of these technologies that allow us to provide absolute quantification of viral loads, really extremely low levels for sensitivity, things I could never do 15, 20 years ago when I started doing molecular, just regular PCR for rabies and things like that. Point of care is an exciting area because now we're finding like small field-based microfluidic devices that public health can take with them. I mean, we're talking like phone-sized platforms that can do things like molecular work, on the tailgate of a truck or something if you had to. All these things are really good stuff. And so, I could go on and on, but that area of genomic, proteomics types of applications are exploding. I teach molecular diagnostics here at Texas State. I created the course back in '02 when I came here. I can't keep up anymore, Danielle. I mean, I do my best, and I always go back to the tried and true stuff. I want my future professionals to backwards and forwards understand specimen integrity around molecular testing. QC QA is so important because you're amplifying all the time. But then just core PCR, core sequencing, Because if you know that, you're building your brain for staying up with all the advancements because you have to have that core stuff. The challenge for me as an educator right now is that, and you're probably similar, I learned a lot of these things, kind of old school. I mean, I had to extract my own RNA from animal brains to get rabies RNA. I had to, I mean, kind of old school, standard, set it up in a PCR device. Now everything's so semi or full automated that you just, man, you can do so much. It's almost crazy what you can do. And so I always tell students the one thing I worry about as an educator. So speaking to educators out there, it's okay to occasionally throw in some of those old school challenges because if students graduate and they go into the world and all they know is kit based, automated based platforms, what happens when something breaks down? Can they do manual PCR? Can they move to that pretty quickly in an emergency? Sometimes I think about it when I watch shows like The Pit or other, we see these shows and some of the things that they do, or how do we handle when a cybersecurity attack occurs and you have to deal with that? And who's usually handling that? People that look like me, gray haired. We've been through that. We did things manually. And so I hope the more seasoned veterans like me and others that are educating or working in the real world challenge, that's part of that training, challenge those new professionals with, hey, what would you do today if that entire platform shut down and you had to have results on PCR for patients? That's when you better have a backup. You better have manual backups where you can start doing good old RNA extractions with the chemicals you need and the right primers. And it may not be perfect or fast, but you could still do it and help with diagnostics and things like that. So I think that's part of the training too, is that we prepare people for what happens if the power goes out. But even beyond that, what happens if you can't even utilize automated systems or jump online to search databases for sequences? I mean, how are you going to deal with that emergency? Because it's probably going to happen at some point.
As laboratory science professionals, I think we need to be so versatile in our expertise. I am a huge fan of building a strong foundation, and that is knowing that methodology inside and out. I mean, just thinking about when I first sat in a molecular diagnostic class, we were the first year to have
Right,
that class. And a couple of years down the line, I'm working in biomedical research, and it's night and day. Like,
right,
this is not we're
right,
already doing this. This is not what I learned, so it's that evolution of that area I know has been really amazing to watch, but being able to do that PCR from the ground up, even when I do automate, I'm like, this is what's happening. But
right,
without that foundation, you're unable to connect that this is what's happening behind the scenes. So if I
right.
had to, I can walk, through that path. And as we talk about empowering these new professionals, we have to talk about that workforce shortage. Uh,
Absolutely.
just last week, it feels like it was so long ago, but just last week, the Workforce Action Alliance met in Nashville along with some other outstanding organizations to talk about the workforce. And this issue is not isolated to just hospital, laboratory, health.
Right.
This is universal.
So I think you're absolutely correct. I've had the privilege and honor of serving with the Workforce Action Alliance as well as the ASCP Blueprint for Action. And there are so many ASCLS and ASM and APHL, right? We could go on and on. So this isn't a one shop thing. We're really trying to work across the country with all of these professional organizations and others. I think one of the, this was pre-COVID, right? We knew that we were seeing retirements accelerate. We were seeing less interest maybe in these fields, or at least to the point where they may have been choosing to go other routes. And so we've really backed that up and started trying to dissect what was important to get down to the middle school and high school levels. We know when we talk to each other how critical awareness and visibility is to those students. And I really think what we talked about last week, and we've been talking about this a while, is we have to talk to high school teachers, middle school teachers. We have to reach advisors. We have to reach parents and really find a way to talk about this exciting diverse, amazing kind of diagnostic detective field that we are in the medical lab and the public health labs, kind of amplify that message of how exciting it is to be to be involved with an outbreak or a mass transfusion protocol to save someone's life in a hospital. You don't have to be a physician, and there's absolutely nothing wrong with being a physician or a nurse or a physical therapist or a pharmacist. But the supply of data, the important amount of information is coming from mostly the laboratory, mostly the laboratories providing most of that data to physicians assistants, to pathologists, to others that are creating that healthcare plan or that diagnostics type of information. So that's critical. Awareness, visibility, education, scholarships, exciting stuff, using social media, using digital media to get into those new professionals as they're young people, not relying on paper-based stuff or old websites or and getting out there and Cola's done a great job with this as well as other organizations showing people's story, telling stories about how they got into this and why it's so important and how awesome it is that every day they're in the trenches of cancer diagnostics, or cancer treatment or vaccine development or whatever it is. There's so much you can do with this background. And then we have the issue, of course, of during COVID, especially it was amplified, but burnout, right? So we really were seeing a lot more during COVID, but we also saw that people that we were already short staffed, and so all of a sudden I had alumni that were reporting 14 days of 12-hour shifts. I mean that is not going to make people happy long term. Everybody jumped in with their sleeves rolled up to help and to save lives, but that's hard to maintain long term. And so high burnout. We're still working both policy wise and organization, talking to hospitals about fair pay. I mean, we do so much that we should be approaching nursing wages, in my opinion, and others. Without us, hospitals shut down. Without us, the world's at danger of the next outbreak. I mean, you absolutely need medical laboratory and pathology professionals. When we see those surges, right, it's mostly seen. All of a sudden, you don't have enough people on board to handle surge testing and things like that. So, my other concern with this is as we continue to retire, as professionals continue to maybe go do other things, all of a sudden, Danielle, you might have fewer staff members that have that long term memory um, to really train and educate the next group of professionals. You might even impact turnaround times for critical surveillance data or things like that because people just don't have the boots on the ground or the expertise there. So we have to keep at it. It is not an overnight fix. I know you and your team and my team here at Texas State. We're doing everything we can to up our numbers. We're bringing in more majors. We take 26 a year now versus 15 or so we used to do 10 years ago. We're trying. But it also means we have to talk to hospitals and healthcare systems and reference labs. They need to take more clinical placements. There's all these issues around clinicals and things like that. So just massive continuing education and thinking a little bit creatively, I think, about our field and how we expose people to it so that it's shown as like this amazing, rigorous, diverse foundational bachelor's degree or even an associate's degree. Now you can get the doctorate, various specialties. You can leave the lab and move into epidemiology or public health. You can go to research. You can go to veterinary diagnostics. You can go to bioinformatics. You can go to regulatory stuff like COLA. I mean, it's all over the place. So you don't have to necessarily be in the lab for 40 years, but we sure want you to be there for a while so that you understand it and can keep promoting it with your friends and family and others.
And it's so important to be creative in your promotion and being an educator. We are keen on meeting people where they're at. And if you're talking to that middle school age, to tell them, especially now as different things come out, this is where the laboratory shows up. This is the laboratory's responsibility
Right.
in this particular outbreak or in this role. This is what they collect, this is what they do, and showing those various lenses of laboratory science, it's so key to
So
us
important.
promoting not only the people coming in, but the pathway of those
Right.
within,
And
that could be
retaining,
a difference.
right? And
Exactly.
retaining. Retention is also big, right? So recruitment
Yes.
and retention. Retention's huge.
Because you can bring 100 people in, and if you lose 75,
That's right.
no, we want to retain and we want to grow that talent into what you were saying earlier, keeping a lot of that knowledge and growing it. And it also helps from a mentorship point of view, having that organic mentorship in place at your facility or organization. It's all key to us growing as an industry. So, as we come to a close, I want to know, what are your hopes? What is your future view of public health laboratories and where it goes?
Yeah, thanks for the opportunity today. I think it's such an important platform that we all take the opportunity to share these thoughts and create those stories for people to understand what we do. I am hopeful. I'm a positive person. At times I'm frustrated. I've certainly been frustrated in the last couple of years with some of the misinformation and some of the issues we've dealt with in the spaces of public health and the medical laboratory. But I think we need to turn that story around and make it a hope chest, if you will. I mean, the career paths and the constant employment of our professionals is a great thing to talk about. I mean, you go through a program like an MLT or an MLS or DCLS or any of the other specialties, you're never going to want for a job. Who can say that when they pick up a diploma? I mean, it's an amazing opportunity to impact people's lives and health. So I'm hopeful. That's my ongoing story. I think the way we went through the pandemic really helped us think about different types of work shifts and different types of way to do things. And I think we're starting to see that creativity in the lab, especially as new professionals kind of take that on. I think an area we have to constantly talk to new professionals about and students is the true realism of resiliency. We have to build that resiliency in our workforce because sometimes there will be extreme circumstances. There will be emergencies. There might even be times where you're afraid, like an unknown pathogen, but to build that awareness and resilience in the future workforce is really, really important. And then understanding your place in the world. I think when I look at students over the last 5 to 10 years, they are they want to change the world, Danielle. They want to save the planet. They want to be green. They even think about things like laboratory waste streams that I used to never really think about. There's so much you could get involved with and to help Mother Earth. And so if we can kind of tell that story to new professionals in middle school and high school kids that, man, you can change the world. And you certainly can change a person's life if you detect cancer or you detect a particular infection and you help them through that process. That's where I'm hopeful. I ultimately think the country will get back to strong public health support. Think about those who support public health in all sectors of the country. Think about that when you go into a voting booth. Think about that when you talk to your colleagues. And I'm not getting political here. To me, it just makes sense that you want to have strong public health, just like you have clean drinking water or anything else that you want to be important to your family and friends. So I'm going to be hopeful. I think that our colleagues are going to be hopeful, and I hope that if you're out there listening, you step up and volunteer, jump in, both hands, jump in there and help because we need you. We need fresh ideas. We need more boots on the ground. We need people that are showing up to do that work, and it is work, but it's so important. And so, thank you so much again for allowing me to kind of talk about my passions today.
Thank you so much for joining us. If you have not heard Dr. Rodi present, you are missing out. It is a wonderful time having you here. I always learn so much from listening to you every single time. So, thank you for being on Talk Lab to me. And until next time, stay compliant, stay curious, and keep talking lab to me.